Joining the program today is Dr. Severance McLaughlin, the founder of DeLorean Artificial Intelligence. He's built cutting-edge tools that help doctors and hospitals spot problems sooner, treat patients smarter, and even save lives before things go off the rails. He's led AI efforts for major companies and advised groups ranging from health insurers to the United Nations, and brings a rare mix of sharp thinking and real-world experience. We're grateful to have him with us today to break down what AI in healthcare really means and why it's mattering. It's going to matter to all of us. And Dr. McLaughlin, welcome to the program.
Well, Peter, thank you so much for having me on and allowing me to share a couple moments with your listenership. So thank you so much.
Well, I've got an audience full of caregivers. And so I want to right off the bat just ask you, what are your thoughts on how AI, a lot of people are very scared of AI. And, I understand that. I work with it all the time, but I understand a lot of people don't. But what are your thoughts on how AI can help caregivers who are overwhelmed and just trying to keep their loved ones healthy and safe?
Yeah, AI can be scary. Any new technology can be scary. And, there is an article that was recently published by Bessemer Ventures, and the title was AI in Healthcare, an Overnight Success, Decades in the Making, an oxymoron. And, number one, any technology that occurs is scary because we may not understand it. And you're probably old enough, and your listenership is as well, to remember the Netscape days of the internet, right? Back in 2000. And
Yes.
we call that that was the bubble, if you will. And previous to ChatGPT and OpenAI, that conversation was very difficult to have about AI and how does that help you as a caregiver, your physician, your nurse, your licensed professional, and your loved one or patient. But now that people have been able to touch AI in real life using those tools, the understanding and acceptance has grown significantly, not only by caregivers, but also by physicians. And that growth from 2019 was 29% acceptance, now up to about 72% acceptance. So basically what our technology does, Peter, is we're the first biologically validated AI, which means that our predictions and forecasts have been proven to be true and accurate by companies such as United Healthcare, Innovative Renal Care, Ascend Clinical. And because we process 84 million patients and we have all this data, and we're able to predict in the future, will someone have a chronic disease and will it progress? And what do we do as the caregiver or as the patient or as the physician to retard that progression or prevent it from happening? And I think if anybody asks that question, right, about being scared, I always give the analogy back to, do you want to be on a plane from New York City to London or New York City to Dallas with just the pilot, just the computer, or the pilot and the computer? And I know I want to be with both the pilot and the computer because there's a fail-safe. And I think it gives an opportunity really to support the medical demands of our healthcare professionals and caregivers.
So let's break this down into some real world things here. What are some of the prediction models that you have? Is it for kidney disease? Is it diabetes? Yeah. Things such as that?
Yeah, so we're in 5 different disease areas. Renal or kidney, which is both chronic kidney disease as well as dialysis, cardiovascular disease, diabetes, COPD, and mental health. And what the tech does for those is it predicts. Number one is it gives you a real-time risk today of a adverse event like a hospitalization happening. But then it predicts in the future, Peter, will that person get better, remain stable, or will they have an adverse event such as a hospitalization or a heart attack or a diabetic event 2 weeks, 3 weeks, 4 weeks out? So we're talking about in the future. And the next thing it does is gives a prediction as to what do we do as a team, the caregiver, the doctor, the patient, to prevent that from happening. So for example, our accuracy in predicting heart attacks in 3 weeks is about 89%. So if you're driving from Denver to the Aspen area, right, and someone has a heart attack, they're going to have a low survivability because they're in the rural area. But if we can predict that 2 weeks out, that person could go to the cardiologist. Maybe it's a pharmacological or a drug intervention, or maybe they have to go for an echo or an EKG. But we've saved that life before putting them into that situation. An, Another example might be someone that's on dialysis, and we predict, hey, they're going to go into hospital because they have too much fluid. Their heart's working too hard, and so right there, if our nurses take our next best actions, 99.987% of the people don't go to the hospital. So
Well, so we're looking at mitigation, we're
yeah,
looking at prevention, we're looking at treatment options way before the event happens. So how do you where does this start? I mean, does it just start going to your by going to your PCP? How do people engage in this type of path?
yeah. So there's two ways really. So we started off serving insurance companies, and then we learned very quickly that physicians, so your PCP or your cardiologist or your nephrologist, really are at the point of care, and that's where you get the best bang for your buck. Is when you're in the doctor's office and the AI is working with the doctor. And I want to make that point very clear: is that we work hand in hand with the doctor. We give them all the information they need. And so the question really is your physician using this technology, and do they have access to it?
Well, that's a very good question because, you're going to your doctor and they may not have any clue to what this is talking about. How widespread are you involved in this with practitioners and so forth? I mean, are you in major like universities or are you out in rural community hospitals?
Yeah.
Where are you guys?
I came off a farm, Peter. So rural health is very important to me, and I think that the AI has a lot there to prevent from hospitalizations and heart attacks and severe acute events. So we're working really, really hard to get into those markets. Currently, we are deployed. Again, I said we've processed 84 million patients. We're currently deployed at over 450 dialysis centers across the United States. We are in 200. We're rolling out to 230 nephrology or kidney doctors' offices, and we are now moving into cardiology practices as well as skilled nursing facilities. So short-term care after a surgery or whatnot, but also long-term care as well.
Back up a little bit to the psychiatric component of this,
Yeah.
of mental illness.
Yes.
Kind of unpack that a little bit. How does that work? Because I mean, with the dialysis and so forth, you got blood markers and urine and everything else that you test for. What does this look like in a psychiatric environment?
Really good question, Peter. And I don't mean to be funny when I say this, but I grew up Irish Catholic, and mental health was not my dad's top priority, right? He always said, "Give you something to cry about." And so it wasn't on my list to want to do as a scientist, because it's very subjective, area of medicine, if you will. And so our accuracy for renal and heart is like 85, 87%, and we're very proud of that. But when you look at mental health, it's 72%. And the story is United Healthcare is a client, and they asked us to do the mental health part. And we worked really hard, and we got to 68% accuracy, and then we got to 72. And when I was showcasing it to the executives, I was like, this isn't as good as I'm usually. I'm very worried. And when we showcased it, they were very impressed with what it was. And what it is, Peter, is it gives the ability to predict objectively, what stage of depression a person's at. So if you ask a practitioner, are they stage 1 through 5? If you ask 3 practitioners, you might get 3 different answers.
Okay.
If you get 3 different answers during medication, they have to titrate. Some of your listeners may have heard a family member say, well, they're working on my medication or trying to figure out the proper dosage. And that means that maybe they overdiagnosed or they underdiagnosed, and they're trying to titrate that medication up. So what our technology does is that it gives an objective with a 72% accuracy of where that is to support the physician in their diagnosis, and allows a faster vehicle, if you will, to getting to the right dosage of the medication.
You're basically giving them the access to the HOV lane.
Absolutely. I mean, I should hire you as our
By the way,
marketing.
you could use that one if you want. My initials are PR, but it's I get that, and I could see the subjective part of it. But I think as we look at the mental health issues going on in our culture right now, which are substantial,
Yeah.
and I'm here right now. We live in Montana, but I'm doing this interview with you in Denver, where we've been here for some time in the hospital, and mental health issues are it just exploding here in this area. And in Colorado here, where it's a big issue where they're talking about it. I see people, addicts and so forth, laying on the ground, sleeping, all this kind of stuff right here. I mean, when I'm walking back and forth to the hospital. So this has been ever present on my mind is how do we go after something like this? How do we mitigate this? What are the intervention methods we can do to pull this back? Now, are you dealing with just depression, or do you feel like that you guys can penetrate into schizophrenia, bipolar, and all those kinds of things as well?
So, multiple good questions there that we need to unpack. So, I completely agree with you that the mental health aspect is huge, and I credit a kidney doctor giving a talk last year to why my belief is that it's so big, and we need to make some uh, uh, inroads there, because people suffering from chronic diseases such as chronic kidney disease or dialysis or cardiovascular, they can become depressed. And if they become depressed and they don't take their medication or are treated for that, that leads to a whole host of advancements in that chronic disease that could have been,
Okay.
it retards it, right? And so we have to treat the patient. I mean, the physician needs to treat the patient with a holistic approach. And so I'm a big advocate of, if we're working with nephrologists or cardiologists, bringing in our mental health as well. And so we are starting to do that. And that you'll see decreases challenges with medical adherence, so taking your medication or going to your appointments, which are very important. Now, you bring up another good point, Peter, about the other areas of mental health, schizophrenia or bipolar. And we have looked at that. The challenge, what we're seeing is we can do depression very well because of the data size. The challenge with the other disease states within mental health is we don't have the level of data we need currently to be able to make the predictions that we need to.
Well, and that makes sense because yeah, I get that. What about what are some areas that you are envisioning doing, but you're not there yet, but you really want that area? You want to put your flag there. What would that look like for you guys?
Absolutely. And the two really great examples are high risk pregnancy and muscle skeletal. So, like, muscle in the back from falls or from strains or accidents or whatnot. So, I'll go back to high risk pregnancy. On our list of things to do is how do we mathematically model this and predict which individuals will have a preterm or a preemie baby, and then how do we prevent that or help the child or the fetus get to a further point in pregnancy or be able to go be naturally birthed so they don't have to go to the NICU and spend all those months there, but also for the maternal or mom's health as well. So that's high on our list. And again, back to the musculoskeletal, which is huge for all of us aging individuals and getting in those long-term injuries. How do we ensure that individuals get the best treatment? And usually, it's physical therapy or exercises at home that extend the quality of care that's needed. And again, huge on to the caregiver in these points.
What about Alzheimer's and other relate like Parkinson's, so forth?
Yep.
My father had Parkinson's, and so my mother-in-law as well. So I didn't know if that was something you guys are trying to wrap your arms around as well.
We are working with a couple academic units and a couple other companies in that. So both of those disease states have a lot of new data that is coming available, as well as data, Peter, that is being collected now. So down to voice or coughing and things of that nature in the voice box that can give premonition to the stage or quality of the disease. So that is something that we've been asked to look at, as well as cancer. And so we're starting to go down those pathways currently. I'll give you an anecdote. One of our clients is a health company that provides in-home nursing, if you will, or visiting support in the Northeast. And they are using Alexas or avatars to talk to their aging population. And what we found is that those individuals are more honest when the avatar asks them how they're feeling versus a home health nurse. And so that data that's collected when the avatar says, hi, Sally, how are you feeling today? Where she might tell the nurse, hey, sweetie, I'm doing great. She's being very honest with the avatar and saying, I'm having lower back pain today. I woke up early. and that small amount of data could alert to a urinary tract infection, or that could have been a kidney function or whatnot, and we can get treatment modality to them faster.
Well, as you say these things, I mean, I'm just so many things are floating in my brain here of cancers, of glaucoma, of all kinds of things going on that affect the human condition here, and I know that you guys are. I mean, this is you're not brand new because you've been doing this for a while, but at the same time, data's coming at you so fast. I don't know how personally you're able to keep up with it, but I do have one final question on a condition, and I'd love to hear your thoughts on it because it's very close and personal to me with my wife. Chronic pain, and
Yes,
and hers comes from, of course, enormous amount of trauma that she had, but managing chronic pain comes with its own set of challenges. You can't just, I mean, we could get her out of pain today, but she wouldn't be able to function. So she'd either be
correct.
sedated or she would be numb, and neither of those are good outcomes. So you have to manage it, and it's like whack-a-mole sometimes. Do you see your models being able to assist chronic pain management physicians in tightening up, a little bit more precise, so we're not throwing things against the wall to see if this works or this works, that kind of thing?
Correct. We're actually working with a pharmaceutical company. We're in discussions, I should say, with a pharmaceutical company on, and I would say this is an area of medical adherence. Peter, is that not every person responds to the same treatment protocol of a pharmaceutical drug or combination thereof. So what we're trying to do now is mathematically model that journey for different types of people. And then what are the different changes, may that be pharmacological or adaptations to home, so that as the disease or the pain progresses, we are treating that in a hyper personalized way to that specific patient. So that it's not one fits all. We are addressing with like an 80% accuracy that we can lower that pain at month one, but the modality we do at month two is going to be completely different.
I understand. What you do is fascinating to me, Dr. McLaughlin. It truly is. When you get up in the morning, what are you the most stoked about that you're getting ready to, be elbows deep into?
Yeah. So if you asked me 20 years ago, would I be sitting here doing what I'm doing? The answer is no. And the journey through my life, and the gift that I have to share this technology with patients and physicians is huge. I'm the CEO of the company, so I get up in the morning to do what I do every day, and I love what I do. Is we are predicting future health events, so people and their families have choices earlier, right? So if we can identify that disease at an earlier stage, sometimes up to 5 years, the conversation with the physician and the caregiver is completely different, and they have different treatment modalities, which likelihood will extend people's lives. And I call that giving more hugs. So when people say, "What do you do?" I said, "I'm on a mission to give more hugs to a grandmother, to a wife, to a husband, to a brother, to a sister." That gets me excited, and that's from a personal level, from a professional level. The ability for us to implement technology that has the ability to predict chronic disease onset as well as progression and change people's lives for that is immensely rewarding. And recently, in the last 2 years, I've been able to meet those individuals that our technology has impacted, and there's nothing better than that. That is what motivates me every morning, is to be able to meet those people that we've impacted upon.
You give a whole new definition to an ounce of prevention is worth a pound of cure.
No,
And
and serious, right? It's 5 years, right? It's a different story. It's a different path.
when you look down the highway here,
Hmm.
and it's 2025, so 2030, what are some things you expect to see? We're not there yet, but you really believe we're going to hit.
By 2030, I think what we're talking about right now, my technology or someone else's technology, and being able to predict, is going to be table stakes and is going to be standard of care. and it's going to be in every doctor's office. There's going to be ambient AI that's recording all the notes for the doctor, and it's going to be inputting it into the electronic medical record. You're going to be able to be precision diagnosed. The diagnosis hopefully will be like 5 years earlier, so the treatment modality will be easier chosen. We're going to be having hospitals of the future where they're fully digitized, and the efficiency. I think pharmacological companies are going to be in line with all of their adaptation as well as development is going to be implemented via AI. So I think and a lot of that's going to have to do with the government and the Centers for Medicaid and Medicare dictating value-based care by 2030 for all types of medicine is going to drive that. Hopefully, from my point of view, the Veterans Affairs will be able to adopt this, so their standard of care, so our great veterans can be cared for. Indian Health Services, Department of Health, for CMS
well, you've got in the Native American population, you've got such high risk for diabetes.
Oh,
and so this would be, I would think this would be just an amazing tool in that world.
There are two groups that are close to my heart. One is Native Americans, and the other ones are veterans, and both are disproportionately affected by diabetes, chronic kidney disease, and heart disease.
And for veterans, mental health disease, because you've got so much are dealing with PTSD or whatever they're calling it now, but depression certainly. But a lot of, when you got 22 vets a day that are committing suicide, we got a problem.
So we can predict suicide, and we believe we can at least reduce that suicide by 10% per day. And so we're trying to work with the government.
Wait, I got to stop. That is astonishing.
Astounding.
Really? Yeah. You can land on that square.
Yes.
That is astonishing.
Yes. And it's in our mission. Like, we are trying to lobby the VA as hard as we can, because I believe if there is a technology that has the ability to predict chronic disease, may it be mental health or suicide or heart disease, it's available. We have a moral obligation as a society to use it. And so I'm on a mission with the VA. We're trying to get into the VA to do this. We have formal white papers on it. Happy to share that with you, Peter. But we're also working with a Native American nation, or trying to, down in Arizona, in dialysis, to be a pilot, if you will, for Indian Health Services. So again, both those populations, there's a lot of opportunity for improvement. And I think, again, this AI is going to be, I believe it's standard of care now, but it will be realized as standard of care by 2030.
Well, I am truly fascinated by this. As my wife's caregiver for this 4 decades journey that I've had with her, one of the things that is incumbent on me as her caregiver, I can't provide the diagnosis, but I'm the historian of her chart. And it's sometimes up to me to make sure, and I had this experience in this last 5-month stay that we've been here, where I had to step in quickly and bring a historical context to my wife's care. I was just actually talking with her ortho surgeon this morning, and that gets a bit tiresome to have that, because I'm a pianist by training. I'm not a physician. And so, but yet, if I don't bring that historical narrative, then things get wonky, and I'm able to step in and keep this thing from going off the rails. Do you foresee that burden on fellow caregivers being lessened through what you're trying to do? So that historical, even if you're in multiple hospitals and things like that, that historical narrative is not going to be laid squarely on the shoulder of the caregiver, which has been my experience. And I'd like to see that hopefully change. And you see this as a realistic possibility.
So, Peter, I would say yes as the short answer. Yes as the long answer too, but two separate answers. Number one, our AI technology integrates into a number of different databases, the electronic medical record, claims, and others. And so what it does is bring billions of records together to the physician at the point of care, and summarizes and gives all the recommendations so that they can practice at the top of their license. So from that perspective, I would say yes, they have all the information they need historically or whatnot. That is available, which is key. The second part of that answer is available, because we have so many different electronic medical records, or you move from one state to the other, or you have a cardiologist, a pulmonologist, and your general practitioner, sometimes those records are not available to one another. So another area of technology is called blockchain, and people would know this from
Right.
Bitcoin, so that nature. Again, maybe when I finish with the AI, this is my next journey. But in 2017 and 18, there was a big push to use blockchain to bring all of our electronic medical records together. And imagine this, we're like, why can't we? Again, the technology is available. Why can't we have a fob on our keychain or our phone that is secure? Technology, Bitcoin is available, that you download from your kidney doctor, and then you go back to your general practitioner and it updates their file, and then you're with your orthopedic surgeon and it downloads there, so they have all that information that is available. So again, the technology is available. We now need to actually operationalize that.
Well, I think the security of that technology is going to be probably the driving issue for everything once, because you're right, it's there. We could do that now, but can we keep it secure? And I don't envy the people that are going to have to solve that particular algebraic question, but that's okay. That's what they do. And once that happens, I feel that I'm very optimistic about what you're trying to accomplish here, because I see it real time with me. And there's so much data. When you've had, in my case with Gracie, she's had 98 surgeries. She's had well over 100 doctors treat her in 13 different hospitals. Well, that's an enormous amount of data. And I'm able to pull that together pretty quickly just because I've had to do it, but a lot of people can't, and a lot of people are the learning curve for that is pretty steep. And I've had to go back and summarize things. I've actually sat down with their surgeons and I've helped draft the summary of it. So we had that data, and so that would be a tremendous burden off of my shoulders, and I'm sure quite a few other caregivers, to have that uniformity of data so that they can predict. Okay, don't forget, because I said this to her surgeon before this particular round. I said, look, don't forget, if something can go wrong with her, it will. And quite frankly, Dr. McLaughlin, it did. That's why we've been here 5 months. Mm-hmm. And he told me, he said, you called it. He said, Peter, I've never seen this happen in all my years as a surgeon. I have never seen what happened with her. And I said, well, Doc, the first time a surgeon told me that, Ronald Reagan was president. Yeah. And I said, but I don't need that responsibility on my shoulders. I take it, but it's not helpful to put that in the hands of a piano player. It needs to be in the hands of a quality medical tool. And this is where what I hear you saying is this: these are the things that we can accomplish. Now, we're not there yet on all of it. It's going to take a while, but I love what you're doing. Can I ask you very quickly before we close? I want to be sensitive to your time, and we're about at the end of ours here. If people want to find out more about you, where do they go?
Absolutely. We're DeLorean Artificial Intelligence, or DeLorean AI. Google us. We're at www.deloreanai.com. My name is Severance McLaughlin. I'm the only one Severance, I think, in the world right now. So feel free to do a quick Google. And Peter, I'd end our conversation with this: is that, again, the technologies are available, but it's the consumer, right? The people that are listening to you who will drive the adoption, right? If enough people ask their insurance company for these types of technologies, or they ask their physicians, then this will become table stakes, as well as the blockchain. So we're all advocates, we're all taxpayers, we're all consumers of our healthcare, and I would encourage your listenership to be vocal upon that.
Well, hospitals are the great equalizer. No matter what station you are in life, race, creed, color, doesn't matter. You're either going to walk into a hospital or be carried into one. There's just no getting around it. And so we all have a stake in this on helping improve healthcare for the human condition here. And I am very grateful to have you on. I hope I can have you back on. Would you come back on?
Absolutely. Anytime. Make sure Gracie's doing well. And,
I will. I'm getting her. We're hopefully leaving tomorrow, and I'll get her home and get her stable. She's gonna be okay. This is just. She's an orthopedic train wreck, but she's tougher than a Waffle House steak, and she's going to be okay. And we're going to get her back. She learned how to ski as a double amputee, so she's made of iron. And
I would say so.
but it's been a journey, and it's been an illuminating journey, and that's why I wanted to have you on today, because this is where my headspace is with when I'm dealing with so many medical records and so many things that are going on with her, and I see it with my fellow caregivers. So I am most grateful for your time today, and I look forward to every time I can have you on the program.
Well, Peter, thank you so much for your time, and thank you for allowing me to be in the homes of your listeners. And all my best to Gracie. Please tell her I send my best wishes and prayers as well, sir.
Dr. Severance McLaughlin, CEO of DeLorean AI. This is Peter Rosenberger. This is Hope for the Caregiver. PeterRosenberger.com.